So this study is about the culture of safety and leadership styles in long-term care facilities in Jefferson County and surrounding counties. Acknowledgement: this study got support from the STTI Sigma Theta Tau and the internal grant from the University of Louisville. There is no conflict of interest. I would like to thank the people who helped me do this study. Ms. Vicky Tensor at the research office, and Chris Hannon, he's a student at the DMB program now. Jessica Jones, she graduated and she's working somewhere in Louisville. And we start with culture of safety. You cannot build a good organization. You cannot have, the goals. You need to develop the outcomes, the positive outcomes. We all want higher quality. We all want less hospital-acquired infections and conditions. We all want less turnover of our staff. We all want all these nice positive outcomes of our care, but you cannot do that without a real culture of safety. And a culture of safety is the way we do things. It's not only nursing, it's all the people who work in healthcare. It should start from top to bottom of the organization, from the CEO, from the managers in all the departments. We should all work together in building a culture of safety. The way we communicate, the way we lead, the way we deal with care errors, with mistakes. We always get who gets blamed most for mistakes? It's unfortunately nurses get blamed mostly for them. What caused mistakes? Based upon the Institute of Medicine report, the most common cause of error and mistakes in healthcare is what? System design. The way the system has been designed. It's not the nurse problem. It's not the physician problem most of the time. It is the way we do things. Effective culture of safety. Motivate workers. If you go to somewhere where the culture is just and you have a good culture of safety, the employees, all of them, nursing, physical therapy, physicians, CNAs, everybody in that organization would have more motivation, more commitment, more productivity, and will have more effective care provided to the resident. Teamwork, appropriate staffing rate and mix, non-punitive responses to mistake, and effective communication, leadership are all part of an effective and just culture of safety. Creating a culture of safety not only promote resident or patient positive outcomes, but also staff positive outcomes in the healthcare environment. Toxic workplace cultures. We have researchers who went on to study the characteristic of toxic workplaces. And what's in these toxic workplaces? What the characteristic of those places? High staff turnover. Very hard to have retention. The staff is leaving all the time. What else happens? Sick leave. They have more sick leave. They don't want to come to work. They're trying to find reason not to come to work. So there is more sick leave and more psychological ill health of the employees. So all these negative outcomes for the healthcare workers. And also what happens on the other side of the outcomes? You'd have more what? More adverse events, more higher rates of hospital-acquired infections, and poorer outcomes of the care process. In long-term care, adverse events do happen. And in long-term care, the people are what? Are older adults. That means they are 65 years and above, which make their health care, their body system is what? More frail. So their ability to come out of healthcare error is what? Is it as good as adults? No, it's much lower. So the resilience is lower. Older adults have lower resilience to care error. So the effects of care error would be more harm and very hard to come out of those care error. There is about 1.6 million American in about 18,000 long-term care facilities. There is a higher rates of care errors and adverse events in long-term care than other populations. Adverse events in long-term care are mainly falls, pressure ulcers, And the prevalence of pressure ulcer can range from 6% to 25%, based upon many factors: skill mix, organizational commitment, and enforcing evidence-based practice. Falls is a problem, and the rate of 1.7 fall per bid, with 10% to 25% sustaining life-threatening injuries. We know the hip fracture, for example, for older adults, usually survival rate is very low. Some studies give them up to 6 months of life following a serious hip injury. Lower adverse events and lower mortality rates have been attributed to appropriate R-N ratio in healthcare organizations. Staffing is a big issue in healthcare. Dr. Aiken and her teams have done a marvelous job, and a lot of publications in many journals, including JAMA and many other prominent journals, that appropriate staffing will decrease adverse event and decrease mortality rate. To have enough nurses on the floor can reduce mortality rate. And that's a very important really findings that we should incorporate. We know the current situation. For example, I come from Louisville, and they're always short-staffed. You know how many we graduate a year? Our class size now is 100 students at the University of Louisville. We're not the only one in the city. There is maybe 4 or 5 schools. We're graduating a semester about 300 to 500 nurses. And there is still a shortage of nurses everywhere you go. And they're always hiring. And the question, why these hospitals cannot retain these nurses? Why? That's the question that we all ask ourselves all the time. If they would have a just culture of health, would they have that high turnover of nurses? And I always tell my students, if you go to find a job somewhere, always ask the question, how long, my dear colleagues, you've been here in this job? And if they tell you we've been here for weeks, for months, that's not a good sign. You know, when I went to a nursing home years ago, I went and I asked, and they had nurses and CNA who've been there for 10 years, for 7 years. It's not there anymore. I mean, I go to the same nursing home now, and I ask and I look at the nurses, they're all new. They're all brand new. I feel sorry for my students. I want to put my student with a nurse who knows what they're doing, and I'm always scared because this is a new nurse. I need to teach their nurses. They don't know what they're doing. They're new. They don't know the policies in the organization. And I feel, and I tell myself, I'm sorry, I won't put you with this nurse. They're just a new, you know, it's limiting even our educational abilities. Although researchers recommended improved communication to improve, you know, the outcomes and to decrease adverse event, communication is still not enough studied in the literature. If you Google and do a PubMed search, or go to CINAHL, for example, search and look for communication in long-term care facilities, it's unfortunate. There is very little about improving communication. So we still need so much work into that. It's crucial in the current changing healthcare environment to identify organizational factors, characteristics that affect adverse event and resident safety culture in long-term care facilities. So that's what we are trying to do in this study. So leadership, effective leadership also, if you go to the search engine and look for leadership in long-term care, it's unfortunate there is very little research done about effective leadership in nursing homes. And you know, with this turnover that we're talking about, with culture of safety we're talking about, with adverse events, it's very crucial that you have effective leaders in these places. And it's unfortunate, you know, if you look at the research done, leadership style, positive one, are associated with what? Higher patient satisfaction, lower patient mortality. Effective leadership is related to lower patient mortality, lower medication error, less use of restraint, and less hospital-acquired infections. And we still are not doing enough to build effective leaders in long-term care organization. I mean, these are outstanding, you know, just this slide, it tells you a story about leadership in long-term care. And that's why when you look at the outcomes that we're always talking about, they're not as good because we are lacking developing and growing effective leaders in long-term care. So our goal in this study here to assess the culture of safety and leadership style and its relationship with organizational characteristics and selected adverse events, which is like, for example, falls and UTIs. The study aims is to identify organizational factors associated with culture of safety, leadership style, and selected adverse event. We also wanted to look at the relationship between them and staff turnover, staffing level, and communication performance. Our study design, we used a culture of safety survey, communication survey, and we used MLQ leadership style survey. These are cross-sectional surveys. We went to the nursing homes, and we called all the nursing homes in Jefferson County and surrounding, and we were only able to have 5 of them who agreed to participate in our study. We also used, we try to increase sample size as much as we can, but we cannot, we only can call, and we made an arrangement to talk to them because we thought face-to-face communication was much better. So we went and we got in 5 nursing homes, and these are the one who told us to come in, really. Every time they said, we're ready to meet with you, we got in, because we went and we did face-to-face meeting with them and explained our study, and we got in. The other part of the data was secondary data analysis from the Medicare and Medicare website. It's called Nursing Home Compare website. And that website have a lot of quality indicators, staffing information, and it has adverse events data. It has the UTIs, it has the falls, it has the pressure ulcer information, and Kevin helped me out with that. We have to download the data. So if you look at the data online, it doesn't have much the same information that you get if you download it. So we downloaded the data, and we get the full picture of the home compare data, including all the data we have. Our sample, we talk about that. There were 9 nursing homes enrolled. Our inclusion criteria was English speaking, and the culture of safety include all the employees in the nursing home. So we surveyed everyone we could in the nursing home, including the nursing assistant, the RNs, the LPNs, the physical therapist, the occupational therapist, the managers in the nursing home, because we want to look at the whole picture and the whole culture in the nursing home. So we have research assistant who went there, and we brought some food with us, Subway sandwiches, and we told them we recruited, and we announced it in a staff meeting, and we try to encourage them to come and get some food and complete the survey, but they could have food and not complete the survey too if they want to. And we told them the survey was anonymous. Do not write your name on it. Do not write your facility name on it. And that was important for the facility. They didn't want to be identified. The resident safety culture survey, we use the AHRQ, Agency for Healthcare and Quality. They have a nice survey, and it has all these domains that it assesses teamwork, staffing levels, compliance with the procedures, training and skills, non-punitive response for mistakes, supervisor expectations, hand-off reports, and that's where the shift report, where the new nurses come to the floor and they get a report from the nurses leaving. And believe it or not, that report is extremely important on the continuity of care, and extremely important, as you will see in the findings, in decreasing UTIs and decreasing adverse events. And many more other overall perception, organizational learning, and management support. The MLQ survey had many subscales: idealized influence, inspirational motivation, intellectual stimulation, and many other scales for leadership. Our findings: 211 respondents completed the surveys. 27% of them were RN and LPNs. 35% of them were nursing assistants, which is who are the main people in the nursing home, usually are the nursing assistants. And then we had 8% who were administrators, 3% were administrative support, and rehab staff was 13%. And I was surprised that the physical therapists and the occupational therapists completed the survey. Now, 98 participants, 46% of the workforce worked overtime. About 50% of the nurses who completed the survey did work overtime. And we have staff shortage in nursing homes. That's why everybody, half of them is working overtime. And we know overtime is what? Is related to higher adverse event, related to higher hospital-acquired infections. The more overtime they work, the more adverse events and other negative outcomes happen. Most of the respondents kind of went to the neutral response regarding compliance, staffing level, and non-punitive responses. And these are the socially appropriate response. So we got some of those. The highest mean score was for communication and feedback about an incident. The second scale was mean supervisor expectations. And the third one was the overall perception of resident safety. These were the highest scales in the culture of safety that they rated. And we found the negative correlation between hand-off reporting and falls. And that's very important for our nursing to understand the value of that shift report. So the better the shift report, the less the falls, the ratio of falls. The better the report that you give to the other nurse coming to the floor, the less is what? The UTIs. And that's a significant correlation between those. And we ran more statistics, and we found that the relative risk of falls increased as the number of residents increased. So the more patients you have in the nursing home, the more risk for a fall, which does make sense. The one that did not make sense to me was that the more LPN hours, the more risk for falls. And that was unexplainable to me, because the more nurses usually you have, the less things happen. But for the LPN, it was higher. Now, when we combine the LPN and the RN, it was the opposite. The higher the hours of work that they did, the less risk, decreased risk of fall at 79%. That's a very high percentage of decrease. And the RN usually have a different preparation than the LPNs. They have more skills in assessment and more skill in leadership. They have a broader understanding of the care process. And I think that can talk to this finding. And the culture of safety score, the higher the culture of safety score, the less risk for falls by 26%, the less risk for UTI by 20%, the less risk for short stay ulcer by 7%. And that's a very significant finding. It talks to you that we really need a positive and a just culture of safety, because it decreases all the adverse events, as we see here, that's mentioned in the Medicare and Medicare website, Nursing Home Compare. And this shows the statistics here that we just talked about. And the pre-last survey, the MLQ scales, unfortunately, were not significant. Did not show in our model here. If you look here, they did not show. We expected leadership to show, and I think it's related to our the way we classified the data from the MLQ, and I think we lost our statistician. So I would like to run the statistics again for the MLQ and see if we can, if we a different division of those, because they can be divided in many ways, and the statistician only use this kind of a scale division of them to relate this data. And our findings suggest that there is a need to build a strong culture of safety to improve long-term care, employee retention, and foster person-centered culture of safety attributes. And we talk about the shortage of nurses. That's why the nursing home have to fill the position, and the LPNs stay more than the RNs. And there is more LPNs in nursing home than RNs, which is unfortunate, because our finding showed that the more LPNs, the higher the falls were. And one option is to develop person-centered culture of safety. There is a program by AHRQ that they develop a certain intervention. We could apply the intervention they did in ambulatory care and hospital setting into the long-term care to develop more interventions to improve the culture of safety. Thank you so much. And if you have any questions, please let me know.